My name is Danielle Kennedy, and I'm the lead diabetes educator for the Diabetes Foundation. It's our pleasure to offer you tonight's exclusive event to help support your health. I'd like to introduce Dr. Ashish Shah, your host for tonight's session. Dr. Shah completed his hematology and oncology fellowship and internal medicine residency at Robert Wood Johnson Rutgers University Hospital at the Cancer Institute of New Jersey in New Brunswick, New Jersey. He is board certified in medical oncology, hematology, and internal medicine. He's currently with the Atlantic Health System, and he is a trustee of the Diabetes Foundation. Dr. Shah, I turn it over to you.
Thank you so much, Danielle. And thank you for everyone who is taking time out of their night to spend this evening learning about the complications of diabetes, either for yourself as a patient or as a caregiver. This topic, diabetes, is near and dear to my heart. I've been growing up as a child surrounded by diabetes. It runs in my family, and my father was diagnosed in his mid-20s. So I've really seen, what it takes to manage diabetes. And fortunately, he's been able to really successfully manage his diabetes for the last 60 years. He's 80 years now, and he has excellent glycemic control. He's got good cardiovascular health. And, he's been able to live with this disease chronically for 60 years without it causing the detrimental complications and side effects that we'll learn about today. And, personally, I was diagnosed also with type 2 diabetes at age 45. So, this last 5 years has been a growth for me to learn how to manage this chronic disease and still balance my life as a physician, taking care of patients, but taking care of myself as a patient. And, for me, that was really an eye-opening experience, but it is possible. It actually enlightens you into ways of taking control of, obviously, your diet, your exercise, and your overall mental and physical health. So I hope that my perspective will also help because I'm a patient just like you. So let's get started. Our topic today is diabetes defense, key approaches to prevent complications. Just to let you know, these complications, when they are mild, may not seem like a big deal, but, the statistics are very scary in that unmanaged blood sugar can lead to 60% increase in the risk of heart attack or stroke, lower leg amputation, infection, adult onset blindness. So these are all quality of life measures and things that would be very difficult to live with and obviously affect the quality of your life. So we know that management is hard and that there are cost considerations, transportation, access to care. So really, my goal as being part of the Diabetes Foundation is to, increase awareness, given that this is National Diabetes Month. We've really been on a blitz to kind of get the message across to all the patients here in New Jersey that come to the foundation, and even to those who have not, just to make them aware that we have these resources available to help you manage this chronic disease. And we want to provide some clarity and give you some tools that will help you manage your health in a better way, and then also give you some direction as to where you can go for help. So I hope, again, this is helpful to all of you. And obviously, as Danielle said, there'll be opportunity for questions at the end. I'd like to also just introduce the panelist of esteemed experts in several fields of medicine and podiatry and dental care that are going to be answering some specific questions that I have prepared for them as well. Dr. Sapan Talati, he's a cardiologist in Cedar Knolls, New Jersey, affiliated with multiple hospitals in the area, including Hackettstown Medical Center through Atlantic Health System and Morristown Medical Center, Atlantic Health System. He received his medical degree from Government Medical College and has been in practice for more than 20 years. He's a dear colleague and a dear friend of mine as well. Dr. Dalmanpreet Ubi is a chairwoman of medicine at Hackettstown Medical Center through Atlantic Health, also the medical director at Hackettstown Wound Center. She treats many patients with infectious complications. She's involved in the Ulcer Prevention Committee, Quality Improvement Committee, medical staff events, and even contributes to our local radio show regarding wound care. She's also a dear friend and colleague, so thank you for being on board. Dr. Keith LeBoux is the Chief Clinical Officer at Delta Dental of New Jersey. He has held various roles at Dental Care Alliance, DCA, Cigna Dental, and has spent over 15 years in large group practices. Dr. LeBoux brings with him extensive knowledge of dental managed care and the dental benefits industry. Dr. Margaret D. Oliveira is a nephrologist in Camden, New Jersey, working at Cooper University Hospital. She received her medical degree from Cooper Medical School at Rowan University and also has been in practice for over 10 years. She's also a volunteer and member of the National Kidney Foundation. Dr. Michael Sears is Chief of Podiatry at Newbridge Medical Center and Director of the Division of Podiatry at Raritan Bay Medical Center, affiliated with Hackensack Meridian Healthcare. He has over 36 years of experience in his specialized field. He graduated from the New York College of Podiatry Medicine, where he also did residency and internship, and is board certified in podiatry and foot and ankle surgery. And finally, Danielle Kennedy is the Diabetes Foundation's lead diabetes educator. She brings many years of experience from previous roles at the Cancer Treatment Centers of America, Achieving Better Control, Inc., and Crozier Medical System. So thank you all for taking time. It means a lot to me personally and also to our community of patients that you take the time to help educate regarding complications in diabetes awareness. So let's begin. So today we'll be talking about 3 objectives. We're going to be discussing hyperglycemia and the symptoms of diabetes that causes. We're going to understand the connection between diabetes and the micro and macrovascular complications that can lead to, again, some of the terrible consequences medically that we just abbreviatedly talked about. And then lastly, understand preventive strategies for diabetes complications and what you can do to manage your healthcare and prevent these from occurring. Next slide. So in terms of hyperglycemia, this is excess blood sugar. When you eat food, just in simplistic terms, oops, sorry. There we go. So just again, looking at what happens when you have diabetes, we eat food, and food is the energy that we use to fuel our cells, specifically the glucose. So when the glucose enters your system, it triggers the pancreas to produce insulin. In a normal situation, the insulin will take that glucose and make sure it is efficiently used by your cells as fuel. However, in diabetes, your cells become resistant to insulin. This leads to what's called insulin resistance. And instead of that glucose being efficiently used by your cells to provide energy, it is in excess in the bloodstream, and that excess sugar or glucose ends up being stored as fat. And those symptoms of insulin resistance, which leads to hyperglycemia, causes these symptoms such as fatigue and hunger and all the other complications that we'll talk about. So this kind of vicious cycle is really, the basis of insulin resistance. And what we'll talk about is what sort of the trajectory of complications that are stemming from this insulin resistance or this persistent hyperglycemia that leads to the complications we'll talk about. Next slide. So again, with hyperglycemia and its symptoms, as you can see on the right-hand side, feeling hungry, feeling thirsty, this tingling in the limbs, frequent urination, blurry vision. These are symptoms, of a newly diagnosed diabetic patient, but also could be a sign of persistently high blood glucose in a patient with diabetes that's under poor control. So, high blood sugar is defined as a glucose level greater than 180 or 200 milligrams per deciliter, or when your blood sugars are abnormally higher than usual. And these symptoms, again, are similar to the acute symptoms at diagnosis, but can be chronic if you're persistently hyperglycemic. So some of the reasons that this may happen may be, again, not enough insulin, or missing a dose of your diabetic medication, or eating more than planned, or exercising less than usual, or stress from either fever, infection, illness, or an outside source. So ultimately, all of this leads to inflammation that can contribute to the complications that we'll talk about that affect many of your system and organ, and can lead to really end-stage complications if not controlled. Next slide. So again, before we get into some of these complications, it's important to know that being a diabetic really means being proactive with management of the hyperglycemia. It all starts with controlling the hyperglycemia, because as you can see from that visual, it's more of a cascade that continues to kind of feed itself. So the sooner you get control of the hyperglycemia and then the complications from a cardiovascular standpoint, the sooner you're going to be able to prevent these long-term complications from actually ever occurring. And that's really the goal of being able to manage chronic diabetes is to not deal with the complications when it becomes end stage, but really make the preventive measures and use the tools that we'll talk about today to help properly manage your glucose. And, starts with the hemoglobin A1C, as we'll talk about. This again demonstrate, like I mentioned, the various organ systems and problems both on the microvascular and macrovascular system that lead to complications. So starting with the eye, high blood glucose can lead to high blood pressure, which can damage the eye blood vessels, as you know, are very small and tight, leading to retinopathy, cataracts, glaucoma, again, from excess hyperglycemia over a long period of time. With the kidneys, you can develop, again, from high blood pressure, damage to the small blood vessels. Excess blood glucose can also overwork the kidneys, resulting in nephropathy. And we'll talk about that more later, as well as neuropathy, where again, persistent hyperglycemia leads to damage to the peripheral nerves, leading to numbness, which can lead to foot wounds and infections, all the way to end stage gangrene and unfortunately amputation in some cases. With the brain, again, increased risk of stroke, cerebral vascular disease, TIA, cognitive impairment. Same thing with the heart, high blood pressure, high force on the heart, leading to insulin resistance and increased risk of coronary heart disease. Peripheral vascular disease, really your lower extremities, leading to these leg ulcers and poor wound healing. Again, end stage, leading to gangrene and possible amputation. So, we've seen, and we've obviously probably been aware of family members who've gone through the end stage complications, and it can be devastating, not for just the patient, but for the family as well. So anything you can do to really focus on the preventive care, I think that's really the golden theme of this message of tonight's talk, where these complications can be prevented if started and treated early, or even managed to be early warning signs to prevent the complications from actually occurring. Next slide. So again, this is really a simple tool that we instruct a lot of the patients, and Danielle will be talking more about this in terms of management tools, but it comes down to ABC. It's obviously easy to remember. A for A1C, hemoglobin A1C, B for blood pressure, and C for cholesterol. And, if you really focus on these three numbers in your toolbox, tracking these numbers, see where you're improving, see where your target should be, you're really going to have a much better chance of reaching those end goals of, staying within the parameters that will prevent, the blood pressure to lead to stroke or kidney problems or amputation or peripheral vascular disease. Same thing with cholesterol buildup and plaque. So really, it starts with ABC, and it's easy to remember. And obviously, there's certain tools that we can provide, but it's about really being proactive and managing your healthcare to the point where these numbers don't get out of control, because that's when it really leads to that cascade of complications where it's very hard to rein it back in. Next slide. So blood sugar and complications. Again, we're going to start with our nephrologist, Dr. Dia Oliveira. Thank you very much for joining us. I just wanted to start with, how do those ABCs impact kidney health in your practice?
So
How do you instruct patients?
thank you so much. For me, I think about the A1Cs, the ABCs independently in patients who have kidney disease are detrimental in and of themselves. And if you have all three, an A1C that's uncontrolled, high blood pressure, and high cholesterol, that is just basically three risk factors for progressive kidney decline in patients. And I see it all the time in terms of how uncontrolled sugar affects the kidney in terms of leading to protein in the urine, which is something that usually your doctor should be checking every year to make sure you don't develop protein in your urine, because people can develop a lot of protein, which results in swelling in their legs and can lead to complications and faster decline in kidney function. And then blood pressure, that in and of itself can cause progressive kidney dysfunction. And we use medications commonly like lisinopril, losartan to help lower the blood pressure and the protein. So it's a double effect. And then cholesterol, that in and of itself increases the risk of kidney disease. So having the ABCs under control from my standpoint is really important to help keep your kidneys happy and healthy.
Thank you so much. And what, can you share, 2 or 3 ways that you help to manage the kidney health of your patients when they are actually diagnosed with, or even early stage diabetic complications of the kidney?
Yeah, so things that I really do is the first thing is I look to see how much protein they have in their urine and what their kidney function is. Because if there's a lot of diabetics have normal kidney function, but they have a lot of protein in their urine. So there are a lot of, it's a really exciting time in nephrology because there are a lot of new medications that are helping to slow down the progression of kidney disease. There's ACE and ARB inhibitors, which is the first line medication to help decrease the protein and help with the blood pressure. And then there are other medications like mineralocorticoid receptor antagonists or non-steroidal mineralocorticoid receptor antagonists such as finerenone and spironolactone that also help decrease the amount of protein in the urine. So I usually look at those to see are the patients on lisinopril or losartan to really help decrease their proteinuria and help kind of keep their kidneys happy and healthy, because we know that the more protein you have, even if it's just a little bit, 300, 400 milligrams, that can really rapidly progress. And that really is kind of, I tell patients, it's like putting your finger on a hose. If you have high pressure on the hose, that's going to lead to the kidney getting damaged over time. And when you have lots of protein that's making your kidneys work overtime, that really puts you at a higher risk of ending up needing dialysis in the future.
That's so important, how you're talking about just all the preventive measures that you instruct your patients, because when you get to that end stage, as you alluded to, the dialysis and, it's just a huge burden of quality of life as well. So, lastly, also, what can patients do to, anything in their lifestyle, drink more water, drink less water, drink certain fluids, like anything they can do in addition to obviously what you've mentioned to help, slow the progression of kidney disease or prevent some of these complications from occurring.
I tell my patients, honestly, I just tell them they have to have a heart healthy diet. They have to exercise, walking counts, having a low salt diet, not eating processed foods, and really trying to keep your A1C within goal is going to be the really best thing for you. And I usually try to say start with something small. If that means walking more and trying to decrease the amount of processed foods, start there. And that can really make a difference in terms of keeping your kidneys happy, but keeping your heart and your brain and every other organ happy.
Well, thank you so much. I appreciate a few minutes from your input, Dr. Oliveira, and I'm sure our patients express the same sentiment as well. Thank you for everything you do for your patients as well.
Thank you.
Next slide. So I wanted to switch to the complications of the foot, and we'll be talking with Dr. Sears. Again, Dr. Sears, thank you so much for joining us. Really appreciate you taking the time and sharing your wealth of experience. So how do the ABCs of diabetes play a role in your view of the health of your patients' feet and their foot-related problems?
Hi, Dr. Shaw. Thanks so much for having me. It really is a combination of effect. When you talk about the ABCs, it's really a combination and associated with peripheral vascular disease and neuropathy. And that's really what leads to most complications. What most people talk about is when we talk about peripheral vascular disease, we talk about macrovascular complications, but you also have to talk about microvessel complications. And macrovessel can lead into poor blood flow, but microvessel actually leads to tissue oxygenation. And when you talk about tissue oxygenation, you have to have a certain amount of oxygen getting to the tissue for wound healing. So if you develop a wound, that's where the microvessel complications come into play. And then you talk about neuropathy. Neuropathy actually comes in three forms: sensory, autonomic, and motor, which are fancy names. Sensory is how you feel, and when you lose loss of feeling, that leads to what everyone calls diabetic neuropathy, where you lose the sensation, you can't feel things, which leads to potential ulcerations. And then you get into motor neuropathy. Motor neuropathy actually changes the overall architecture of the foot, which leads to muscle imbalance, which leads to increased force load, which thus ends up leading to potential ulceration. So it's really a combination effect. And the last that most people don't talk about is autonomic effect. So you talk about the ABCs. This all leads into everything with the potential complications. When you talk about autonomic effect with diabetic neuropathy, you also are dealing with loss of sweat, which leads to dry skin, which leads to cracking. And skin is your first, for those of us that don't know, skin is your first line of defense. And you can have microscopic cracks in the skin that we cannot see. However, to a bacteria, it's like the Grand Canyon, which can lead to infections. So you put all of those things together, it's really the ABCs just come down to vascular disease as well as the development of neuropathy. So it's really all in my world. And I tell patients this, Dr. Shaw, it's prevention, 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 prevention. When you think you're preventing, prevent even more. These are the type of patients that really I end up having to operate on, the people that kind of convince themselves I'm getting better, I'm okay. And 3 or 4 days later, they end up in the emergency room.
Thank you so much. That was so comprehensive and really helpful for us as well. I had a question, do you see in your practice kind of a correlation between the hemoglobin A1C control levels, those that are sort of, maybe borderline diabetic or, good control, maybe their hemoglobin A1C is somewhere between 8 or 9, but they're kind of, getting close to goal versus the ones that come to see you and they're like off the charts, 15, 16, 20. Like, do you find that clinically there's a difference in what you see?
Well, you do. I think that whenever you have high hemoglobin A1C levels, my mantra is just about all diabetics have some form of neuropathy. And therefore, I educate all my patients, even if their hemoglobin A1C levels are within normal limits, 5.8, 6.0, high normal. I educate them about neuropathy. But when you start dealing with any of the higher hemoglobin A1Cs that you were talking about, and then you get to the really, really high ones where I've just had a patient at 12, 13, 14, you're really dealing with patients that are at increased risk for diabetic ulcerations, limb loss, things of that nature. So you do see a difference, but I think that any of these folks with high hemoglobin A1Cs have high levels of glucose, which is affecting their nervous system, which then leads to diabetic neuropathy. And also, once again, it goes back to what most people don't think about. Stability in your gait cycle is based on motor function, and the motor function has to be in place. Well, okay, we talk about feeling, but at the end of the day, when you have high hemoglobin A1C values, it changes the architecture and structure of the foot, which leads to increased plantar pressures, which then lead into development of ulceration.
Thank you. And Dr. Sears, what do you recommend to your patients in terms of what they can do, in terms of prevention? Obviously, that, as you mentioned, prevention, prevention, prevention. What are the tools that you recommend, and what would you recommend as to support good foot health?
Yeah, I think first off, I would like to make this comment is that anyone who smokes and has diabetes immediately quit, because the bottom line is that certain disease processes or certain things that you do to your body, whether it's smoking or uncontrolled blood sugars, leads to pathology in certain sized blood vessels. So smoking is more small to medium sized blood vessels, and diabetes is more micro vessels, small to micro vessels. So you have kind of a double whammy in your tube, leading down and carrying oxygen, nutrients, and all of the things that we would need for healing to the area and to stay healthy. So one of the things I would tell anyone is to immediately quit smoking. If not, you're going to have dire complications. And I see it every day, every week. That said, some of the things that we can do for prevention is first and foremost self-exams. Look at your foot 2 to 3 times a day. 6 is better than 5. 5 is better than 4. As many times a day. And when you look at your foot, not only look at your foot, look at your lower extremity. As a podiatrist, I'm a specialist in the foot, ankle, leg. So you will get wounds, scrapes, scratches on your leg that people miss. But from a examination standpoint, look in between the toes, where the toes bend, top, bottom side of the foot, ankle, and leg. The other thing is offloading inserts for your shoes. Go to a healthcare professional. Someone can prescribe or send you to a ped orthotist, not orthopedist, ped orthotist. And they can make a diabetic offloading insert for your shoe, because it's all about offloading pressure points. That prevents potential ulcerations. Creams and lotions, whatever your choice is, put the creams and lotions top, bottom, side every day. And this is to prevent dry cracking. If you remember, we talked about earlier, autonomic nervous system decreases your overall ability to sweat, which leads to cracking. You want to hydrate your skin. So therefore, put creams and lotions, but the one place you never put it is between your toes. So that's one thing you need to do. Also, rotate your shoes daily. Never wear the same pair of shoes. Antifungal powder in shoes, things of that nature. Check your shoes before you ever put the shoes on to make sure there's not a foreign body into the shoes. I actually, the other day, a paper clip slipped off one of the counters, was in my shoe. I would have had no idea. I am not a diabetic, but if I was a severe diabetic with vascular disease and neuropathy, I would have never known that could have led to devastating consequences for me. The other thing is that most people don't think about is having your feet measured. Everyone walks into the shoe store and buys a shoe. I'm a size 9. I go to the counter. Have your feet measured prior to having that. But when you have your foot measured, in the old days, if you remember Dr. Shaw and all of us, you sat down and they put the little metal thing there and they measured your foot. You do not want to do that. You want to be full weight bearing. So you want to stand up. And if you're having your right lower extremity or right leg measured, and your foot in this case of the right side, you want to put all your weight. It changes the overall architecture of the foot. It lengthens the foot and widens the foot. And when you measure the shoes, make sure that you measure from heel to the distal tip of your the end of your longest toe. Some people's toes, their second toe is longer than their big toe. That is where you want to measure, or else you can end up with ulcerations. And I've seen that in my practice, because everybody from their mom teaching them, they all grab their big toe when they're measuring their shoe. Do not do that. Check your foot, make sure that it's second toe. And the other thing that I would say is, if you have a wound and it ever develops, I don't care where it is, at the end of the day, cleanse it. Do not leave it open. Everybody, it's an old wives' tale that you leave wounds open to the environment to let them dry out. Do not do that. That leaves them open to every bacteria there is in the world. You cleanse it, nice mild soap and water, put a topical antibiotic, keep it covered at all times. And I will tell you, my advocation is to immediately seek out a healthcare professional so that you and that doctor can monitor you. And that leads to prevention. It's the people that I find that wait, I thought it was going to get better, et cetera, that I end up having to take care of from a surgical standpoint and an advanced medical standpoint.
Thank you so much, Dr. Sears. That was incredibly thorough and extensive and, informative. I think a lot of us take this for granted, whether we're diabetic or not, like you said, in terms of foot care and proper
Oh,
foot
thank
care.
you.
And, I think what you highlighted are simple, basic, practical ways that you can take care of your feet. And especially for diabetics, so many times in my practice, or even with family members, the stepping on a nail, or stepping on, like you said, a paper clip,
Exactly.
a thumbtack in the house, even a chip of paint. I mean, things that are sharp, that are just embedded in the carpet or on the floor. And, for a diabetic, that, like you said, could be devastating complication down the road, toe amputations, foot amputations. So, these
Absolutely.
can lead to devastating infections and, things that may be irreversible, of course, if not treated early. So anything that can be preventive, as you mentioned, was again the key to the message. So appreciate all that input. Thank you so much.
Thank you. Appreciate it.
Am I saying that properly, Dr. Lebu? Is Dr. Lebu?
LeBeau.
Lebeau, I'm so sorry, Dr.
It was
Lebeau.
very close.
I tried. Dr. LeBeau, thank you so much for joining us, Dr. Keith LeBeau from Delta Dental. Again, as we're talking about systems and organ systems, we've talked about foot care, we've talked about kidney and nephropathy. So in terms of oral care, can you explain, just for the audience, how diabetes and high blood sugar can impact teeth and oral health in general?
Sure, Dr. Shah. So the first thing to realize is that that gum disease, gingivitis and periodontal disease, are a response, the body's response to a bacterial infection. And the bacterial infection is due to plaque buildup, bacterial buildup that becomes a plaque and coating on the teeth. And the inflammatory response, the gingivitis and the periodontal disease, is an inflammatory response to this infection. And as the infection progresses, as the body's immune system responds, uh, the disease progresses, the periodontal disease progresses, ultimately leading to a loss of the gum tissue, the pink gums on top and the bone underneath that really hold the teeth in place. Where diabetes comes in is, as a condition, diabetes weakens the immune system. So the body's response, the inflammatory response to the bacteria on the teeth, to the plaque, and the immunologic response is very damaging as the body's immune system is more challenged to fight it off. And you'll see a more rapid and progressive loss of the supporting tissues that hold the teeth in place. Beyond that, people with uncontrolled or poorly controlled blood sugar levels also can have a higher level of salivary sugar. And the salivary sugar, it just exacerbates the problem because it creates an environment where bacteria that coalesce and form on the surfaces of the teeth and cause uh, the damage to the supporting tissues in the mouth, the gingivitis and the periodontal disease, uh, can proliferate. Uh, so it really is a cycle. It's uh, periodontal disease and gingivitis is going to happen if the plaque forms is not removed from the teeth, and it's an immunologic response. And if somebody's immune system is suppressed or not working the way it should, you'll potentially see more damaging loss of those tissues that hold the teeth in.
So, in terms of our diabetic patients, what can they do? What are simple things that they can do to, prevent some of the complications you mentioned, when they're in their early stages, or even preventing them from happening at all?
That's a great question. The first thing is they really should work very closely with their medical team, with their primary care doctor and their medical team that's working to control their diabetes. That's absolutely critical. Uh, Beyond that, uh, excellent home care. We all hear how important dental home care is. And that really comes down to really good habits to get the plaque and the bacteria off the teeth every single day. And an individual's home care really should be designed, with their dentist and their dental hygienist. But in general, it comes down to getting the bacteria and the plaque off the teeth, which means flossing. Effective flossing every single day. It's probably one of the single most important things anyone could do. Uh, Oral rinses, antibacterial oral rinses. And I typically recommend those that are alcohol free. And then very good, effective brushing habits are also critical. Drinking lots of water is important. And I'll reiterate, quitting smoking, because it does have a very bad impact on gum disease, and especially for individuals with diabetes. And I would also add, uh, check your check your dental coverage. For example, with companies like Delta Dental, for individuals that have conditions, systemic conditions like diabetes, it very well may open up an enhanced set of benefits where they could get their teeth cleaned more frequently. And that's really important because patients sometimes can't do it all by themselves. And having those additional cleanings could be very important.
That's something I didn't even realize was an option for diabetic patients to potentially have more frequent cleanings, like you said, getting to the root of the problem, no pun intended, to really prevent these dental complications when they're in very early stages, or preventing them from even developing in the early stages at all. Like you said, the basic tools that you said, and incorporating the primary care team, because as all of these complications are, we're focusing on specialists that deal with their one area of expertise, but this is obviously a chronic systemic disease that affects really the whole body. So, you know, it's important, like you said, to collaborate with the rest of the medical team. So I thank you so much, Dr. Lebow, for joining us tonight and for providing this input to all of our patients.
You're welcome.
So I'd like to turn over a few minutes to Dr. Ubi. Thank you so much, Dr. Ubi, for joining us. I wanted to first ask you if you could explain the types of patients that you see, specifically diabetic patients with infectious complications. You know, what type of clinical complications from an infection standpoint do you see?
Just as we said, as my other colleagues said, that when you are seeing to a podiatrist, your goal is predominantly to prevent, and prevention is the key in diabetes. When you end up seeing an infectious disease doctor, it is bad that you already have infections. And from my standpoint, what preventive measures that you can do is a better glycemic control. So if your blood sugars are much better controlled, you are less likely to get any type of infections. Be up to date on all your vaccinations, your yearly flu shots. Now, surprisingly, we haven't had much uptake in flu, but it is going to come later. Every year we see a different pattern of when the flu increases. So make sure you have had your flu vaccines. All our patients who are diabetic, especially over 65, should consider their RSV vaccine, which is available, your up-to-date pneumonia vaccines, COVID vaccines. All these vaccines, anything that you are eligible, this is the best preventive measure not to get these infections. Diabetics, if they do very poorly with much more complications. A diabetic who gets COVID is more likely to have more complications, especially respiratory complications or other complications, or even with flu. We don't think that way, but people get severe complications with respiratory compromise if they get flu as a diabetic. As we had talked about earlier, from an infection standpoint, you will see that diabetics, newly diagnosed diabetics, we see very much often that they come in with a bad infection and they get diagnosed with diabetes. Very common skin abscesses, skin infections is very much common. They never knew they were diabetic. They come in with a bad infection and their hemoglobin A1C is 11, 12, 15. I've seen as high as 15. Very, very important to do all those preventive measures so you don't end up with any infections. If you're checking your feet daily, you're looking for those early signs, you're seeing your podiatrist on your recommended schedule, looking at your shoe, we see as they don't have a good glycemic control, they're neuropathic, they step on something. We have seen, you name it, diabetics step on a nail, stepped on a glass, and they end up with a bad infections, and it can be really, really bad. And if they get something, it's quickest thing is called, every diabetic should have a podiatrist they should be following up, no matter what. There is no reason they should be calling their podiatrist, say, I have something on their foot, come to the wound center. I am sure Atlantic has wound centers everywhere. They are more than welcome to call any wound center. They'll be happy to see them. So don't wait till it's late. When it's late, then it becomes really bad. So think of organ, respiratory infections, skin infections, any of those infections. If your blood sugar is not very controlled, it can be really bad.
And Dr. Ubi, what are your thoughts about, why are diabetics more at risk for certain infections? You mentioned glycemic control. Is there anything else from an infection standpoint that makes them more prone to have worsening infections or more risk for sepsis?
It's more so that their immunity is so low that they do catch up anything that is out there. Even just a little viral infection could be easier to catch. That a little common cold, it can turn into bad, because we are seeing this year rhinoviruses, which is common cold in our layman's term, metapneumovirus and parainfluenza. All of these are common cold viruses, but people were just getting a little sore throat. But now, and especially diabetics, people who are smokers, diabetic and smokers, bad combination, diabetic and COPD, diabetic asthma, they are getting much severe respiratory issues with any of these common cold viruses either.
Thank you so much. And Dr. Ruby, the wound center that you run in Hackettstown, what kinds of modalities, would be useful for patients who have early stage infection, but obviously want to prevent, or you're trying to, heal their wounds appropriately so that they don't develop into amputations or anything end stage?
So we do have every specialty on staff at both wound center. Actually run both Hackettstown and Newton Wound Center. So we have all specialties, including podiatrist, infectious disease, vascular surgeon. So we do a multi-specialty approach in make sure we have, if they have a problem, if there is a vascular issue, we are looking for their circulation, they need any type of insert, we'll have them help with the insert, any special shoes. Let's say there are patients who do end up losing some, we can have special inserts or whatever is needed. We are help them get it. They don't need a referral to get into a wound center. All they have to do is call the wound center, say we want to come in, and they will go through everything else on the back end.
Excellent. Thank you so much, Dr. Ruby. That was very helpful for me as well. And I'm sure our patients appreciate all the resources that you just provided and some options for them to be directed towards as well. So thank you again for taking time to join us tonight.
No problem. Thank you.
Next slide. Last but not certainly least, we have Dr. Talati, well-known colleague and friend of mine as well, and well-respected cardiologist through Atlantic Health. Thank you for joining us, Dr. Talati.
Thank you, Dr. Shah. I mean, I'm really glad to be a part of this esteemed panel. Thank you.
So I guess, the one thing that I'm sure patients want to know is, the vascular changes that you see from a cardiovascular standpoint, that occur with elevated blood sugars, like we've been talking about. Some people have hemoglobin A1Cs that are, near goal, but slightly elevated. And then those that are completely out of control in the 10 to 15 range, what do you expect to see early on versus end stage with that?
So, I mean, again, that's a great question. So, as it says that, cardiac complications, mostly it's considered a macrovascular complication. So, unfortunately, just being a diabetic, it puts you at a higher risk. So, a lot of, primary cares or even the patient, you can, there is actually an app on, it's available. It calculates your 10-year risk of atherosclerosis, ASCVD risk calculator. If you just put diabetes, like you are diabetic, you become intermediate. So your risk of developing a cardiac event goes beyond 15%. That's what's considered an intermediate risk. So unfortunately, yes, if you are uncontrolled, if your diabetes, if your A1C is not controlled, definitely it causes a lot of complications that was mentioned by my other colleagues, and that itself all adds up. It increases the risk of cardiovascular events, but just being diabetic, it causes increased risk of cardiac events itself. And the reason behind that, Dr. Shah, is that if you look at the molecular level, right, one of the dreaded, I would say, the heart complication is heart attacks and what we call coronary artery disease. And the reason it happens is because of inflammation. That's what we have found out. It's atherosclerosis, where a small lipid molecule, as the slide shows, it basically enters the inner lining of our artery, that is the endothelium, and diabetes actually causes endothelial dysfunction. Interestingly, there are like two, I don't want to go much in detail, but there are like two different pathways that are working in an opposite way. one which helps to constrict the arteries and one which helps to dilate the arteries. Being diabetic, you are in the wrong end. You're at a higher risk of developing constriction, where the arteries, they try to get narrowed because of the nature of the disease, and that leads to what is called endothelial dysfunction, inflammation, and it causes proliferation of atherosclerosis and ultimately narrowing. So, and that it's not just seen in coronary arteries. Unfortunately, it's seen in the rest of the vascular bed. It's seen in carotids that supplies blood to the brain. It is seen in peripheral vascular disease, and that can cause all those foot issues that we talked earlier.
Thank you, Dr. Talati. And, obviously you talked about diabetes itself. What can patients do, in terms of managing their cardiovascular health? Obviously, we've all talked about the hemoglobin A1C, but what other ways can they minimize that cardiac risk that you calculate for them, that intermediate risk or even high risk for some of these patients? How do you get yourself back down to sort of a lower baseline risk? What can you do to extend that potential risk of mortality from a cardiovascular event?
I mean, again, great question, right? So, I always say to my patients that, cardiac disease or heart disease, it's more of a systemic process. So, I can't just focus on the heart. We have to look at the other systems. So again, you want to have your blood pressure under control. The goal is less than 120/80, that is alluded on the slide. You want your cholesterol to be under control. So again, there are certain guidelines that we follow. So your total cholesterol should be less than 200. Definitely, if you are diabetic, you should probably have your cholesterol checked more frequently. I would say definitely annually with your primary care physician. Normally, in a person who's not diabetic, we would say that their LDL goal is less than 100. But I would really emphasize that in a person who is diabetic, we actually consider them as coronary artery disease equivalent, meaning they are at a very high risk to develop cardiac disease, cardiovascular disease. And that's why we prefer that LDL goal less than 70. And, even in my practice, of course, lifestyle changes comes first, where, diet, DASH diet, Mediterranean diet, exercise at least 30 minutes or 45 minutes a day, more of cardio exercises. And if you are not able to get your blood pressure and your cholesterol, as the numbers that we discussed, then you should be going on a medication sooner. Of course, as I said, TLC, therapeutic lifestyle changes, comes first. And if you're not able to get that, then that's what I do in my practice, to put them on a statin. You need to lower their LDL to goal to minimize the atherosclerosis that we talked earlier. One more thing I would just like to point, what happens in diabetic patients is, since we did discuss before that it does affect the nerve endings, so just like it causes peripheral neuropathy, unfortunately, like one of the common symptom when somebody is having angina or chest pains, it probably may not happen in a diabetic patient. And that's why it may be very difficult sometimes to identify those patients earlier if they're having coronary artery disease. So again, seeing a primary care physician, getting all this tests done, and if you have any additional risk factors that can cause coronary artery disease, such as, again, if you are hypertensive, if you have obesity, if you have a strong family history of coronary artery disease, I would recommend that they should be seen by a cardiologist and necessary testing may be done. So in my practice, sometimes, even if they're not having much symptoms or significant symptoms, I would probably perform a physiological testing such as a stress test. As again, you never know that you would find out that somebody at a certain age, if they're, let's say, walking about 8 to 9 minutes on a treadmill, they're not able to do that. So that itself could be an important risk prediction that I would say. Besides that we have now a lot of tools available. We send patients for some imaging tests like a calcium score that also checks for a plaque buildup in the arteries. And that also helps to further risk stratify. And also I discussed about some models like ASCVD risk calculators. We have Framingham risk calculators. So that gives us more additional information, how to categorize, how to deal, what tests should be ordered, what tests should be ordered for the patients. But again, if from a patient perspective, if you have any other traditional risk factors for coronary artery disease, I would say that early referral to a cardiologist definitely makes sense.
Thank you so much, Dr. Talati. And I think you've, really brought the message home too, that as everyone else has on the panel, that early detection equals prevention. And, we fortunately, especially in the cardiac world, now have all of these diagnostic tools at our disposal that you can instruct patients on how to actually quantify their risk, which I think, gives, again, that sort of assurance, right? Like if you're doing everything you can, controlling your blood pressure, your cholesterol, getting the hemoglobin A1C, you can see that risk score maybe come down from high risk to intermediate, and give them, this 10-year kind of probability that might be improving. And, you need sometimes, when all of this is coming down as to what to do to prevent chronic health issues, it's nice to also have the reassurance of a positive feedback, where you're doing the intervention and now you're seeing that, years are being added back to your life potentially. And I think that also is a motivating factor as well for hopefully a lot of these patients. So thank you again. Sorry, I muted myself. So again, I think I'd like to just once again thank our esteemed panelists. Every one of you provided so much, not just to the patients, but to myself as a physician, a fellow physician and fellow medical care member, some tips that I can use for myself and for others in our family. And as a caretaker that, will really help drive home that message that diabetes is manageable, that patients can be proactive and take control of their lifestyle and life, whether it's not just all about diet. There's so many factors involving diabetes. It's not just the food you eat, but it's, like you said, caring for your organ systems and preventing these complications from arising and minimizing your risk and being able to live a normal life, which is what we want for our patients, to live a happy, normal life for as many years as humanly possible. So thank you all for joining us. And lastly, I want to turn over the end of the presentation to Danielle to really talk about the tools that we mentioned that can help patients, manage their disease in an effective way, and also talk about the resources that we offer at DF for these patients. So Danielle.
And thank you, Dr. Shah. Thank you, everybody. This was a great presentation. I appreciated everybody's individual insight and your specialty, and I know our patients do too. And this here is just a simple tracking tool that I wanted to remind a lot of the people that I see on this call, a lot of our patients I see regularly and have definitely seen this tool, but it's a reminder that it's really important to take charge of your health. We use this personal care record just as a starting point for you, as a simple tracking tool, and we encourage you to, and empower you to be able to use something similar to this or use this tool on a regular basis to monitor what you should be having done regularly and what you're entitled to as a person living with diabetes. We all understand that, that since we heard this session today, that there's a lot we can do to be proactive. You can see here that this care record is broken into 4 sections, including lab tests, exams, education, and immunizations. And as a person living with diabetes, you are the center of your own care. Therefore, you need to be informed about what is necessary to care for your diabetes day to day, every few months, on a yearly basis. And seeing your providers regularly and getting the tests done that they order is part of your job and your role as a person living with diabetes. Following the guidelines, as previously mentioned by our ID doctor here on immunizations. And then additionally, the biggest part for me is supporting you with education. Diabetes Foundation does a lot more than that. I'll talk about that in a minute, but we encourage you to, continuously through your diabetes journey, check in with us, have that education upon your diagnosis, whether or not you go from prediabetes to type 2. Annually, if needed, when you aren't meeting your treatment goals is also an option, and when complications develop or new life transitions may occur. that ongoing education for several parts of the self-management piece of type 2 diabetes, and even helping through your journey of type 1. I know there are some here. We can support you on a regular basis in doing that. And, it's really important just to highlight that also these tests that you see here are just things that you can also identify and speak with your doctor about. Ask the questions. We want to empower you to be able to be your own advocate and support yourself throughout your journey. Next slide, please. So I just wanted to, before I wrap up, I just wanted to go through a couple of the Diabetes Foundation's programs here. We have a variety of free, high quality programs, including education, which is offered throughout the calendar year. And it includes a diabetes self-management program, a 1 hour a week series that I teach myself that covers a variety of topics to support ongoing diabetes education and learning, and a diabetes prevention program that we also just partnered with somebody to help facilitate for our pre-diabetes patients. We also offer peer-led social support groups, a guidance program, helping patients navigate free and affordable resources, and A1C screenings that we offer throughout the high-risk communities in New Jersey. So we offer a lot of free services, and we just want to remind you that they're all available to you, and you can all go onto our website, and I can read that, www.dfinc.org. Next slide, please. Thank you, everyone who came out today. Thank you for, I just wanted to thank everyone, our presenters and the companies that they represent. And that's, my piece, but Dr. Shah, I think we do have a few questions. If I know it's 7:59, if we can just take a few minutes to do that.
Sure,
Is
sure.
everyone okay with that? Okay. So let me I have a couple here. I want to ask actually a question, I think, for me. Are any, for the diabetes educator, or any specific vitamins recommended for diabetes treatment? Would a simple, good quality daily multivitamin suffice? I would say, I always recommend to eat what you can as a variety. I mean, this could be a long-winded answer, so I'm just going to keep it simple. The more that we eat a well-balanced diet, a heart-healthy diet, a diabetes-friendly diet, which of course is a loaded, statement. So I would say make sure you get education on what that really means. But, a multivitamin can't hurt if it's a good quality. I would encourage you first to get some lab work done. There's other things we may need to support your immune system, but making sure you have that lab work done first would be my recommendation. Otherwise, a simple multivitamin can suffice if you think you're not meeting your intake of fruits, vegetables, whole grains, things like that. Okay, so next question. For the Dr. Is it Oliveira? Sorry.
Okay.
What are the early signs of diabetic kidney disease, and how can I monitor them?
This is a great question, because the thing about kidney disease is it's silent until it's too advanced. And that's the thing that I see a lot of the times, is that patients only go to the doctor when they have swelling in their feet. And that may be a sign that you have lots of protein that you're leaking into your urine. It could be from heart disease. There are a lot of complicating things. So that's why it's really important to advocate for yourself and get your yearly kidney function, basic metabolic panel, renal function, comprehensive metabolic panel, to keep track of what your kidney number is doing. And what I tell my patients is, I say, this is what your creatinine is. They should tell you two numbers. This is what your creatinine is, and this is what your eGFR is, your estimated glomerular filtration rate. And that's basically the percentage at which your kidneys function. And I think it's very powerful to tell patients what the percentage is, because if we tell a number 1, 2, 3, 4, it's a number. But if you say percentage, 60%, 70%, 80%, I think it paints a better picture of where your kidney health is. So it's really, that's the scary thing about kidney disease, is that it's only in the blood work until it's really advanced.
Thank you so much. That is really informative. It reminds me to, remind our patients here today why it's important as a person with diabetes to get to have a visit with each of the specialties that you're entitled to. And I think that's really what I drive home when I talk about, making sure that if I highlight complications in my class, that's what I talk about: going to a cardiologist proactively, seeing a nephrologist at the first sign of any kidney damage. And I think That's why we keep that personal care record available to our patients, because then they know, here's your kidney labs that you will be monitoring, and, you know, helping them to kind of empower themselves. So thank
Okay.
you for that.
Yep.
And also dental related, sorry, sorry, I just lost everyone who is here. So can my diabetes medications affect my dental health? I'm not really, sorry. Yeah.
Can you please repeat the question?
Sorry, can my diabetes medication affect my dental health?
Well, it can in certain ways. Depending on the medications, it's very possible that it could contribute to dry mouth syndrome, which is a lack of saliva, and when there's not good salivary flow in the mouth, it could result in greater plaque accumulation, bacteria, and you know, kind of contributing to accelerating the gum disease. That would be one of the most likely influences of that. I also wanted to mention, as individuals with diabetes, particularly if it's not well controlled, could also have delayed wound healing, as we might see elsewhere in the body. But it's very important for a dentist to be aware of that, because if somebody's getting an extraction or some type of invasive procedure, it's really, really important for them to be aware of it.
Thank you very much.
You're welcome.
And I think, Dr. Shah, I'm gonna transition back to you to close it out, if you don't mind.
Sure, thank you.
Bye.
Once again, you know, really grateful for all of our audience members and patients who support the DF and also attended today's session, and also our expert group of panelists who all took significant time out of their day, I know, to come and prepare for these questions and to participate and really provide such great proactive and preventive strategies for, you know, not just diabetes in general, but really specific complications that we all fear that can develop end stage for a lot of our patients if their disease does get out of control, and things that you can do to actually prevent these complications from arising or delay their onset, which will ultimately, you know, lead to better quality of life for all of you out there. So again, as Danielle posted the website, and there'll be some information for contact, feel free to, you know, look into getting involved with DF, both as a patient, as a caregiver, and use the resources that are out there, that as was laid out today, and you know, spread the awareness. This is November, National Diabetes Month, so if you have a patient, caregiver, family member, especially during Thanksgiving and the holidays, this would be a great time to start those conversations and to make sure you do a check-in on your loved ones. So thank you again, and have a good night.
Thank you. Thank you, everybody, for being here. Thank you for your time.
Thank you.
Ew.
We're here to help. You can find the Diabetes Foundation on Facebook, Instagram, and Twitter.